Hey guys, welcome to Practical EMS. I wanted to try a little bit of a different format out this week, and maybe for the next couple of weeks, and just kind of share some of my thoughts with you about things I've learned from doing the podcast, things I've learned from interviewing a lot of guests around burnout and how to really thrive in emergency medicine and not just merely survive working in a very difficult field. Over the last few years talking with people, I feel like I've learned some really good lessons, and I have what I call standards that I've established in my own work-life balance, if there is such a thing. And I kind of want to share some of those thoughts with you guys. So this will be a little bit of a different format. It's just me today, no guest. And I hope you don't mind, but I'm going to read some of these thoughts I've kind of put down on paper, and hopefully this resonates with you guys. So this is kind of the introduction I have to introduce these standards to you guys and kind of where I'm coming from with these, kind of my background story, and kind of how I've established these patterns, these mindsets, these standards in my own life. And I hope this will be really helpful for you guys. So bear with me as I kind of read kind of the introduction of these standards to you. It required 6 of us to lift the 300-pound, lifeless, pulseless human onto the stretcher. My white shirt was already damp with sweat from taking multiple turns performing chest compressions, and I could see the sweat glistening on the foreheads of the firefighters around me as we struggled to lift the patient into place onto the stretcher, our collective adrenaline pumping from the excitement of a critical case that required our full scope of skills. We buckled the patient onto the stretcher, and we all squatted down to perform a team deadlift. This was before we had automatic stretchers, and we brought it up to normal height to begin the roll from the front door to the driveway to the ambulance. I climbed up on the footrail of the stretcher to resume chest compressions while the rest of the group moved the procession down to the waiting ambulance, which spat out exhaust into the cold morning air. After a couple more tricky lifts of the heavy stretcher, we locked it into place inside the ambulance, and I balanced between the bench and the stretcher to keep pumping the chest. Our ambulance had a crew of 3, since I was a brand new EMT and my partner, a brand new paramedic, were in the orientation phase after first getting hired. Our paramedic preceptor hopped up front while my partner, several of the firefighters, and I piled into the back. The driver hit the gas and the lights and sirens wailed suddenly into the morning air, with no regard for the sleeping residents we passed. I traded off doing chest compressions with a waiting firefighter while we watched my paramedic partner and the fire department paramedic handle tasks whose complexity I could only imagine. They looked at the moving lines on the monitor for rhythm checks, they felt the patient's throat periodically for a pulse, administered drugs I couldn't even spell the name of, through a line we had placed in the shin bone, called an IO. They shocked the patient at various times, choosing not to shock at others. I watched with great admiration as the paramedic intubated the patient while we bounced around the bumpy Colorado roads and performed chest compressions at the same time. That was my first cardiac arrest, and it was exhilarating. To be part of a team focused on doing everything possible to save a life gave me a sense of purpose and confirmed in that moment that I would devote my career to emergency medicine. I was hooked. It was more dramatic in many ways than any TV or movie portrayal could ever be. You might be asking what the outcome of that cardiac arrest was, but the truth is I don't remember. I don't remember what happened when we got to the emergency department. I don't remember if the patient survived because I've run that exact call, that exact scenario, countless times in my 16 years in emergency medicine, causing most of them to blur together. If I had to guess, the patient probably didn't survive. People usually don't survive a cardiac arrest despite our best efforts. That's an unfortunate reality that TV and movies don't portray. If we're doing CPR, chest compressions, their chance of survival is abysmal. Looking back on that call, though, it wasn't the outcome that motivated me. It was the fact that everyone did everything possible on this patient's worst day, and that's what stands out. We don't always get everyone back from the brink, but we always try. But backing up, before I was an EMT, I started college with vague ambitions to become a doctor. That first semester was a significant wake-up call. I realized just how much time and effort college required and how long I was going to have to maintain that level of rigor while continuing to work full-time. At the time, I was working 40 hours a week at a local grocery store just stocking produce, but I was undisciplined and unaccustomed to truly applying myself. High school was so much about just getting things done, but college you actually have to understand the content. It was too much. I dropped out after one semester, demoralized and thinking I didn't have what it took to become a physician or even succeed in college for that matter. I still wanted to work in medicine, but I didn't know what that would look like. Someone in my life, and God bless that person, told me to get my EMT certification. I didn't have a clue what that meant, but I was lost and needed direction, so I signed up at the community college. I didn't research the career, I just figured one semester was doable. I was fluttering in the wind, and the quick suggestion of a friend was all it took to put me on a course that would stay for the rest of my life. emergency medicine. I still remember walking around my college campus tasked with getting 5 different random students' blood pressures as a nervous EMT student. I remember carefully placing the blood pressure cuff around their arms, worried I might hurt somebody, and gently placing my stethoscope against their skin as I awkwardly maneuvered the strange device that seemed so foreign at the time. I remember the thrill of riding in the back of the ambulance for the first time, holding on tight while going lights and sirens to a real emergency and having no idea what was going to happen when we got there. I was still struggling to understand the scope of what it meant to be an EMT. I recall the struggle with time management when I was in paramedic school, trying to balance home life with work and class time each week, all the new drugs I had to learn, trying to remember how to read a basic EKG. I can still get my heart rate up just picturing, after I was a full-fledged paramedic, how stressful it was to be an hour from the hospital with no other paramedic on scene to bail me out while trying to paralyze and intubate a patient all on my own. But I remember that feeling of victory when I shocked a man back to life minutes after he went into cardiac arrest because we were in the right place at the right time to act quickly. I also remember the feeling of complete defeat when I failed to save someone, maybe because their death was inevitable or maybe because we didn't act quickly enough, maybe we didn't get there in time. I remember standing outside my ambulance at 2 a.m. in the morning, textbooks propped up on the hood, trying to get through chemistry paperwork that was due in the morning. I remember driving patients to the hospital from way out in the middle of nowhere, trying to glance over at my organic chemistry protein side chains, trying to commit a few to memory before the final I'd have to take after getting off shift. It took me years longer than the average student to get my undergraduate degree because I was a full-time EMT and then paramedic for most of that 10-year period, while I slowly but surely worked my way towards PA school. PA school was tough, but it was even tougher not working full-time and not making any income during that period. Starting in the ER as a brand new PA came with a steep learning curve that was brutal for about a year and a half before I started to feel a little more comfortable in my ability to practice medicine without consulting a physician every 5 minutes. My progression was gradual, consistent, climbed through emergency medicine over about 10 years, and it was a pace that allowed me to work full-time and continue to provide for my family while pursuing more and more education. It was a long road, but I value my time as an EMT and paramedic immensely. It made me the clinician I am today. In the last couple of years, I've finally been able to poke my head above water for the first time since really 2008 when I began my journey through emergency medicine as an EMT student. I've been able to look back on my climb with more clarity and recognize the skills I had to develop to be successful. I had to push through many tough times and care for thousands of patients to get where I am today. I now take for granted the things that new EMT students are only beginning to comprehend. And I've realized there are principles, fundamentals, and standards in emergency medicine that I must hold myself to if I want to continue not to just survive, but to thrive in this crazy field. These are standards that took me a long time to learn, and I still relearn them more often than I care to admit. They are goals I strive for, but don't always hit. If you Google standard, as I did a little while ago, you'll find a lot of different definitions, but the one that I like is having recognized and permanent value. Standards don't change over time. Standards are the line in the sand that you strive never to cross. They are the bar you aim to meet with everything you do in life. In medical legal cases that evaluate possible negligence by a medical provider, the jury is asked to compare that provider's care to that of a standard provider. Did they meet the standard of care? Did they do what the standard of care dictates? Did they act as a typical provider would? If not, their care is deemed negligent, and the provider will likely lose the case. Therefore, standards are not a vague, unquantifiable measure. They are specific, and it's often obvious whether or not they are being met. Standards are also different from principles. Principles are generalizations you accept as truth and use as a basis for action, but standards are reference points, benchmarks you use to compare what you did with what you should have done. A measurable mark that was either met or not. They are what you're aiming for, even if you don't always hit them. When someone has low standards, they're aiming beneath their true capabilities. But we've all seen people with very high personal standards achieve levels of success we aren't sure we could ever reach ourselves. Standards also act as precedents. Precedent is something you use as an example for how to handle similar situations in the future based on what has worked in the past. They are habits you build day by day that eventually become automatic. You handled something well yesterday. Now you can handle it better tomorrow because you've learned what works. Standards allow you to assess whether you succeed in what you set out to accomplish. Did you meet the standard or not? Did you come close but still fall short? Did you exceed it? No one is perfect, least of all me. I wasn't gifted with talent, high intelligence, a fast metabolism, or born into wealth, but I have learned the ability to set high standards and stick to them, day after day after day. Of course, sometimes I fail. I let stress, anxiety, and worry defeat my mind, which causes me to lower my daily standards and fall short of what I initially aimed for. For years, I struggled with binge eating. I would start every day strong, packing healthy food for work, drinking tons of water, but inevitably something would go wrong. I'd have a difficult or stressful call, or it would just be a hectic day with no downtime. And I would justify that I deserved a treat and grab a free donut from the EMS crew room at the hospital, and one small indulgence would trigger a total collapse. I'd throw in the towel, pick up a pizza on my way home, and park myself on the couch, drinking soda and eating until I was stuffed. Sometimes I'd be great all week and sabotage myself on the weekend, convincing myself I deserved it, and this pattern repeated far more often than I'd care to admit. I had a long list of excuses. I was busy, I was working full-time, I was in school, life was stressful, my job was stressful. I figured when life got easier, I would have time to focus on my health. It would happen later. I had no confidence in myself or my ability to get healthy because I constantly, daily broke promises I had made to myself at the start of the day. I couldn't seem to do what I said I wanted to do, the things I knew I needed to do. The standards I desired seemed out of reach. I couldn't take action on the daily tasks I know I needed to be done because I was undisciplined in major areas of my life, and I lacked any kind of consistency. I lacked execution on the standards I know I needed to change my life. In 2023, I found a program called 75 Hard that changed my life. The program is hard enough for long enough that you begin to establish a new identity, and one that holds the line on standards you know you should be meeting in life. If you miss any one of the daily tasks that it lays out, like drinking a gallon of water, completing 2 workouts, one has to be outside, reading a nonfiction book, taking a progress picture, and eating no cheat meals, you fail the entire program. You can't eat a single cheat meal. You must stick 100% to the diet you lay out. And for the first time in my life, I began to develop consistency and discipline. Motivation eventually drops off, but the daily grind of doing what you know needs to be done sticks, even on the days you don't feel like it. And in fact, those days are the most important because they teach perseverance and discipline to push through, even with zero motivation. It taught me what I really can do, the things that I know I'm capable of. Sticking to a program for 75 days is long enough that old habits die and new habits form and solidify. These new habits begin to shape a new identity. Old Aaron would have a tough day and grab a pizza on the way home to binge on in front of the TV. New Aaron has the same tough day but goes for a run or does a cold plunge instead because he has the mental toughness to make the better long-term decision instead of just reaching for a short, mean dopamine dump. My standards for my daily routine, my mindset, and my life are much higher than they used to be. I hit the bar I set far more often. I'm still far from perfect, but I'm better than I was. Compared to some people, I still have a long way to go to accomplish all that I want, but I know I'm better than I was a month or a year ago. Comparing myself to who I was yesterday is the only comparison that matters. Those daily wins compound until others can see the change in me. These new higher standards allow me to take better care of my patients and keep the emergency department moving efficiently. When I've handled the habits that help me improve every day, I have more energy and drive to pour into others. These standards help me show up to work feeling on top of the world, and when things go wrong during the day, they don't derail my goals anymore or shake my mental toughness. At least not for long. I plan on thriving in emergency medicine and helping others do the same, but I couldn't help anyone until I raised the bar in my own life and started taking better care of myself first. Now, I know as you read this, you might be thinking, great for you, that's not for me, I'm far too busy to make any changes. If that's you, go ahead and just ignore this advice. It's probably not for you, but if you find yourself motivated to change, rather than make excuses, then I think you'll find value here. But still, that motivation has to come from you. I can't make the decision for you. I can't persuade you into wanting to change your behavior unless you've already felt that spark within yourself. Now, this isn't about doing 75 hard, although I think you should. It's about raising the bar in your life. It's about recognizing that certain standards exist and choosing to hit or exceed them consistently. It's about moving from ignorance of those standards to having detailed awareness and then action around them. As you hear about these standards, consider how they affect your life and your career. I believe they're directly applicable to anyone working in emergency medicine, but they can also be applied to any career or life situation. Believe me when I say, when someone's life is on the line, they need a clinician with the highest standards possible. When your family is on the line, they need a husband, wife, father, or mother whose standards are the highest they can be. When shit truly hits the fan, will you be caught unprepared or ready to stand and fight? It took me 16 years of working and studying in emergency medicine to finally understand these standards and their importance. Whether you're a new EMT, paramedic, nurse practitioner, physician assistant, or physician, I don't want it to take you 16 years to learn and apply them. Maybe you're not involved in emergency medicine at all. Maybe you're a new parent, brand new to your career, just burned out and depressed. I don't want you to keep struggling. I want you to develop the ability to raise your standards and achieve whatever you want in life. I want you to be able to take control of the situations you find yourself in, whether they're self-induced or forced on you by external circumstances. Locus of control is an important concept here. When properly applied, it can lead to greater career satisfaction. I want to bring it up here because if you're convinced that everything around you is out of your control, that you have zero influence over your life, then change becomes irrelevant. Sure, many factors are beyond your control, but I want you to shift away from those and towards the things you can control, because those are the only things worth focusing on. When I worked on the ambulance, my day was entirely dictated by dispatch and call volume. Often I felt completely out of control, and that led to burnout. Many careers are like that. Your day is not chosen by you, it's chosen for you. Even within emergency medicine, different roles afford different levels of control. As an ER provider now, I have a little more control over my day than I did as a paramedic. I can decide when and how quickly I see patients to a degree. I can choose how much time I spend with each one. I can decide within reason when I can stop seeing new patients near the end of my shift to help get myself off on time. As a PA, I don't even have the obligation to see every patient that comes back because I'm often working as a team with physicians. I get to influence quite a few different factors, and that gives me at least a small measure of control that lets me decide my fate. Of course, what you can control will vary depending on your role, but in emergency medicine, where most of my day is shaped by whatever rolls through the doors, I can still point to things I do control, and you can too. The principle of locus of control matters. You must focus on the things within your influence and reduce your attention on what you can't control. If you look, there are more things in your sphere of influence than you might think. On the ambulance, we still controlled several factors. You can control your emotional response to a late call. You can control how quickly you write your report and how well you've kept up with your charts before that late call comes in. If your kids are pushing every last button at home, use it as a moment to practice mindfulness and fortitude. If work has handed you a rough day, control how you cope. Lean into strategies that benefit you in the long term, not the ones that offer only short-term gratification. When you feel out of control in the ED, on the ambulance, or in life, look for what you can control, then move to influence as much of it as you can. I refer to these standards as emergent because if you treat them as non-emergent, non-urgent, or something you can put off, they will eventually become emergencies. Anything you know you should be doing today but keep putting off until tomorrow will eventually become a major problem. Skip workouts or healthy eating over and over again, as I've done, and at some point you'll face a major health issue. Maybe not tomorrow, maybe not next month, but it will happen. It is not a matter of if, but when. Treat your healthy habits as non-negotiable, and your physical and mental health won't become emergencies. When you treat these standards as emergent, they rise on your mental priority list. They gain weight and importance. Ironically, once you stick to these emergent standards, they start to lose their power. As you check them off one by one, they become fuel for your growth. They decrease your stress. They increase your resilience. They reduce your chances of being overwhelmed by burnout. Instead of constantly reacting to crises, you'll spend your time sharpening your sword, preparing yourself to handle crisis with calm and poise if it arises. You become prepared. Being in emergency medicine for 16 years has taught me a lot of lessons that I've developed into these standards. One that I'll discuss later is this: you can't help someone who doesn't want your help. When I was new to medicine and discovering the wealth of knowledge most lay people don't have, I often gave unsolicited health advice to friends and family. Many of us do this when we're new in medicine. We're excited about what we've learned and eager to share insights that might benefit those around us. But what I didn't realize early on is that no one really wants your advice, especially about their health, which is a deeply personal and often tied to long-term habits. Advice that hasn't been actively sought out is rarely heeded. At best, it's ignored. At worst, it pushes people further away from you. Sometimes a friend or family will ask for advice because they're ready to change and genuinely want your opinion, but in my experience, that's the exception. We can't change people who haven't already made the decision to change. I've come to realize that it's much better to live a good example and offer advice only when it's solicited for than to offer unsolicited advice. I've learned that forceful advice doesn't change a family member's behavior. A few years ago, my dad had a heart attack, and prior to that, he'd been having some concerning symptoms that in hindsight were probably precipitating symptoms, some exertional chest pain, things like that were, precursors to the full-on heart attack. And my mom kind of told me about some of these symptoms, and I still stuck to my mindset that I only offer advice when it's asked for. My dad didn't ask my advice on these symptoms, so I kept mostly silent. I didn't offer my advice, didn't offer my concerns. I mean, working in years of emergency medicine, they've taught me that I always consider the worst case scenario before the benign one, but I chose to remain silent in this scenario, trusting that my mom would call me if things got worse. And that one night where my mom had talked to me earlier in the day, she called to say she was taking my dad to the hospital. I could hear him groaning in pain in the background. She said that he'd been having sustained chest pain for about 4 hours and that she was done waiting. She was taking him to the hospital. I quickly told her which hospital to go to, sent a few texts to make sure the right resources would be ready, and jumped in my car to meet them there. I arrived only a couple minutes after they did. Their van was still in the ER circle in front of the parking lot. The front door was ajar, vomit was on the pavement, and I was scared. A loved one having an emergency is far different from managing a stranger's emergency. My dad always had been the type to push through pain and ignore potential health problems. He was in his 60s and seemed healthy overall. No limits on his ability to work. He still put in long hours at a physically demanding job. Providing for the family had always been his top priority, and his health had taken a back seat for most of his adult life. My apprehension grew as I rushed into the department, showing my name badge to bypass anyone who didn't recognize me, and I found the room they'd moved him to just as the EKG tech was finishing the 12-lead EKG, and it took 1 second just to glance to know my dad was having the big one, a full-blown STEMI. A heart attack serious enough to show major changes on the EKG, and one that required emergent intervention by a cardiologist in the cath lab to open the blocked artery. I've seen that EKG many times, seconds before a patient cardiac arrests or after we've shocked them back to life. It's not a good one to have. It warns of major badness ahead. I turned my attention to my dad, groaning in the hospital bed, pale, sweaty, barely aware of his surroundings. And the EKG was terrifying for me, but what scared me more was the pain in his face. I don't know if he'd heard me when I told him he was having a heart attack. My colleagues did a phenomenal job, from the physician to the nurses to the radiology and techs. Everyone acted fast. The physician got the HPI and exam done quickly and made the appropriate phone calls to get the cardiologist in without delay. They found a blocked LAD, one of his coronary arteries, and placed a stent, likely saving my dad's life. My dad recovered, but that emergency opened my eyes to my own health journey and exactly where I was on the road to heading. Maybe not in a few years, maybe not in a decade, but in a couple decades, at the end of the line, when you ignore your health, this is where it heads. Regardless of age, we're all heading towards some medical emergency. The real question is, will you delay that emergency or increase your chances of surviving it? If you're physically fit, you're more likely to survive a heart attack. If you eat right, you might delay it by a decade or more. Would you rather have a heart attack in your 50s or your 70s? This experience, despite having seen that scenario play out countless times in patients, was personal, and it motivated a change in my behavior, my habits, my discipline, and my standards. Of course, there are other motivations too. Seeing the older, burned-out physicians who hate their job, treats patients poorly is another major motivator for me. I refuse to become that person. I've seen what that looks like, and I want no part of it. When you witness a family member's health deteriorate or a senior colleague's terrible bedside manner, you have a choice. You can ignore it, or you can use it as a pivot point to change your path. I chose to use it and harness that emotion it stirs up and channel that night in the ER as a pivot point in my life. From that growth, I've been able to crystallize the standards I want to live by, the standards that will allow me not just to succeed in emergency medicine, but to succeed in life. These skills are transferable across careers and life situations. But if they're really worth anything, they should be. But they're also perishable, so you must be applied intentionally and consistently to both work and life as often as possible. Now that's my introduction to these emergency standards. And the first of these is do not seek to diagnose. I remember a shift not long ago working in the ED as a PA when an elderly woman came in with shortness of breath and chest pain. She was tachycardic, she had a fast heart rate, and mildly low oxygen levels, as measured by the little finger probe we place on every patient. During my initial evaluation, I listened to her story, performed a physical exam, and began considering the possible emergent causes, as I do with every patient. This clinical picture strongly suggested a need to consider a pulmonary embolism or a blood clot in the lungs, given the combination of her fast heart rate and low oxygen levels. When I talk with a patient, I rarely focus on finding the ultimate diagnosis. Instead, I focus on determining what workup they need. What labs and imaging will help us rule out the dangerous stuff. In this case, I thought the patient needed a CT scan of the chest, as it would rule out that pulmonary embolism, but also give us a detailed look at the lung tissue, enough to check off other possibilities like pneumonia, thoracic dissection, pulmonary edema. A chest x-ray might miss some of these, but a CT scan won't. So I ordered the scan and reviewed the results. No pulmonary embolism, but there was fluid in both lungs and around the heart. Now, neither of these problems had to be solved in the emergency department, as long as the patient was stable, and she certainly was at that point. But they also weren't problems I would feel comfortable sending her home with unmonitored. She needed that fluid removed, and that process wouldn't be quick, so I messaged the hospitalist to admit her. The hospitalist replied back to my message, "Well, what's the diagnosis?" I said, "There's fluid in her lungs and around her heart." He responded, "That's not a diagnosis." And he was right. I was wrong. What I found was a problem, not a cause, not a specific diagnosis that explained why the fluid had built up. But in emergency medicine, we don't always need to know the etiology. We don't need a diagnosis in every case. Sure, it's great if we can find one, but it's not essential to move the patient forward along the right path. It wasn't emergent for me to discover why she had fluid in her lungs and around her heart, and truthfully, we in the emergency department are often not equipped to determine the underlying cause. What is essential is identifying dangerous problems in the first place. That's our job. My workup doesn't have to reveal the diagnosis, just a dangerous condition that makes it unsafe to discharge the patient home. Once I've done that and ensured they don't need an emergent intervention, my job is essentially complete. At that point, it's up to the medicine doctors and specialists to continue the evaluation, figure out what the underlying diagnosis is, such as a heart condition or heart failure, and treat it long term. The point is, I don't need to know everything about this patient's condition to help move her up the chain to the appropriate specialists and care. If I had waited until I had all the answers, I would have unnecessarily prolonged her stay in an already bogged down emergency department and delayed her evaluation by a medicine physician, which was inevitable anyway. Sometimes we have to move forward without all the answers, and that can be frustrating, both for the patients and the providers, but we often don't get all the information we'd like in the ER. A hospital admission allows time for longer tests and treatments and opportunities to observe the patient's progress before sending them home. This can be an especially hard concept to explain to patients during a short ER visit. But medicine has its limits, and that's especially true in emergency medicine. Time and resource are limited in the high-volume settings where we often work. We're equipped to find and treat emergencies, life-threatening conditions, but for everything else, not so much. We don't have every possible test, lab, or imaging modality at our disposal. We only have what's necessary to rapidly identify and treat conditions likely to kill someone. We also don't have the ability to schedule a patient for future testing or consultation. If it doesn't come back quickly, we can't reliably follow up on it. I understand why this frustrates our patients. They come in wanting to know what's wrong and often why it's happening. They want to know why they're having abdominal pain. And even when we diagnose them with something like appendicitis, they want to know why that happened. I don't blame them. I'd want to know too. So when I approach a new patient in the emergency department, I don't do it with the mindset of diagnosing their condition. I approach it with the goal of ruling out the dangerous, emergent, life-threatening pathologies that could be occurring. I try to set the expectation early in the visit to help avoid disappointment. I usually say something like, if everything comes back normal, we might not get a clear answer today about what's causing your symptoms. Our job is to make sure it's not fill in the blank. Then, if all the tests are negative, the patient's less likely to be upset, at least hopefully. No news is often good news. A positive result, on the other hand, means something bad has been found. In the emergency room, we usually can't give certainty unless it's bad news. A positive test isn't good news. In fact, sometimes the best outcome is we don't know exactly what's going on. I have this conversation multiple times a day, and honestly, it's far easier than the conversation that starts with, "You're sick enough that we need to admit you to the hospital." Emergency medicine is unique among medical specialties. We assess patients, order appropriate workups, diagnose and treat what we can, then move the patient to where they need to go. That destination could be the ICU, a hospital floor, outpatient follow-up, or home with primary care follow-up instructions. This modern obsession with getting an answer may be a holdover from the COVID pandemic. During that time, everyone wanted to be tested. Everyone came in with classic symptoms, but they needed confirmation. They wanted to see that positive COVID result. When this happened 100 times a day, we had to start educating people. Yes, you're 99% likely to have COVID. Stay home. Stop driving around town looking for someone to swab you. A positive test won't change our recommendations. Even in rare cases where it turned out to be another virus, the advice was the same: limit your exposure to others. The same mentality still shows up with the flu and the 20 or so other viral upper respiratory infections that circulate each year. Yes, we can diagnose that specific virus, but it doesn't change the treatment. We're still only going to treat your symptoms no matter which virus is causing them. Now, obviously, there's some subtleties to that with, specific antiviral medications, but this is a generalization that these upper respiratory viruses often do not need any specific treatment, so pinpointing which virus it is really doesn't matter in most circumstances. But people get really caught up in their symptoms, and who can blame them? When you have these sensations in your bodies that suggest something is wrong, when your body isn't functioning normally, it's natural to worry. So they analyze, Google, and research everything they can about what might be happening. We see this every day in the ED. A patient Googling their symptoms reads the worst case scenario and shows up convinced they're going to die. Often I can talk them through their concerns without needing any specific labs or imaging. I explain why I don't think their fears are warranted. And sometimes that conversation leads to a full workup, labs, imaging, everything, just to prove objectively they don't have the condition they fear. Of course, there are times when those tests reveal that their concerns were actually well-founded, and sometimes we find a specific dangerous diagnosis. But there are also many causes of symptoms that we simply don't diagnose because they're not life-threatening and will resolve on their own. These are often clinical diagnoses like costochondritis, gastroenteritis, ankle sprains. There's no single test that can tell you with 100% certainty that you have one of these conditions. But once we've ruled out the dangerous causes, these are often the most likely explanations. So the approach, and again, this is difficult for many people to accept, is you likely have a benign condition and nothing emergent. Medicine is not 100%. We ask patients to return if their symptoms worsen or change so we can reassess. But overdiagnosis is a major problem in modern society, and it doesn't improve well-being the way people often assume it will. Yes, we have access to incredible technology. Our CT scans are highly detailed, and MRIs can detect cancers in very, very early stages. But that level of sensitivity sometimes leads us to find incidental issues that would never have caused a symptom or affect the patient's life. Yet now the patient carries that label forever, often with no real treatment or follow-up needed. For example, we frequently find small pulmonary nodules, benign lumps of tissue, while scanning someone for a completely unrelated issue. A CT scan to rule out a pulmonary embolism might reveal one of these nodules. Most of the time, there's nothing to do except re-image the area every couple of years to make sure it doesn't evolve into a lung cancer. But emotionally, for the patient, it can cause enormous stress. That nodule would have sat there undetected and asymptomatic for their entire life, but now becomes a constant worry. Another example that comes up a lot is brain aneurysms. These aren't problems until they rupture, if they rupture. But we find them all the time on head CTs. And yes, there are procedures that can reduce the risk of rupture, but now the patient faces a stressful decision. Do I undergo a dangerous procedure in my brain, or do I live with the risk of a brain bleed that might never actually happen? And every headache they have, that worry reoccurs. And of course, in the ER, they're going to get a lot more scans of their head, so we can prove this isn't a brain bleed from the known aneurysm. A prominent case is the anatomy ultrasound performed during pregnancy. It can catch abnormalities early, which is a good thing, but it also frequently reveals subtle findings that may or may not matter, and these create enormous anxiety for expecting parents, sometimes for no reason at all. Certainly some incidental findings lead to positive outcomes. We catch more conditions early, but we also burden patients with knowledge about things that would otherwise never have affected their lives, and that stress is real. So we face a recurring dilemma in medicine. Does the benefit of a test outweigh the downside of burdening someone with an unhelpful or anxiety-inducing result? If you're the kind of person who can brush off these incidental findings, see them for what they are, something to monitor but not obsess over, they likely won't affect your quality of life. But many people already have a baseline level of stress and anxiety, and for them, these incidental findings dial up the anxiety exponentially. They fixate on that abnormality and spend their days wondering when it will turn into an emergency. Even worse, some people use a benign diagnosis as a lifelong excuse. They hold on to it and let it define their limitations. They use it to justify inaction, to avoid change, and ultimately to settle into a life of mediocrity. Others go the opposite way. Even when given a life-altering diagnosis like multiple sclerosis, they refuse to be defined by it. They choose not to identify with the diagnosis. They adapt. They overcome. They live better, not worse, because of what they've learned to endure. Here's a hard truth in medicine. If you're healthy, medicine is more likely to harm you than help you. That's a reality we confront every day. No tests, no treatment, no medication is completely without risk or side effects. So when someone is essentially healthy, seeks a diagnosis for a mild or non-dangerous symptom, they may be exposed to more harms than benefit. Now, when you're critically ill, the risk-benefit equation clearly supports aggressive treatment. But when your life is not in danger, that same intervention, whether it's a medicine, test, or procedure, might carry more risk than reward. In those situations, the act of seeking a diagnosis can do more harm than good. The truth is, life is full of aches and pains. The mental stress often shows up as physical discomfort. We can run test after test to make sure a pain isn't deadly, but there's no scan that tells us whether your pain is coming from the weight of your life stress. And if a patient really wants a diagnosis and we don't find one, they often go online or from doctor to doctor searching for a physical answer when the real answer is psychological. Of course, many patients do have complicated medical problems, some conditions that take time to diagnose because they're so rare. They present in unusual ways. But these are not the patients I'm talking about here. I'm talking about the patient who builds their entire identity around a diagnosis. Sometimes it's a benign finding discovered 20 years ago, and they've been worried about it ever since. They expect that any day now it will be the thing that kills them. They mention it to every clinician, even when it has no bearing on their current symptoms. They've handed over their entire locus of control to that diagnosis. Somatic symptoms are a huge challenge in the ED. We see patients every day with symptoms that aren't caused by anything definitive. Chest pain, shortness of breath, abdominal pain. The human body is complex. And those same sensations can be caused by emergent problems like heart attacks, blood clots, appendicitis. But on the flip side, mental struggles, stress, anxiety, anguish can cause exactly the same symptoms when the body fails to properly process life's difficulties. Life is stressful, I get it. Life can be hard to cope with. I've seen a 90-year-old woman with the flu handle it with stoicism and grace, completely composed. And then, on the same day, a 19-year-old young man with exactly the same virus fall apart completely mentally because he's been coughing for a few hours. Illness affects everyone differently, but there's no denying that your mental condition dictates how you experience symptoms in your body. Pain is especially difficult to assess for that reason. I've seen patients with infected kidney stones who don't even want pain medications, and others with a basic stomach virus demanding the strongest narcotics we have. Pain is subjective. You can't feel what the patient is feeling, and as providers, we've been walking a tightrope for years because the medical community helped create the opioid epidemic by being far too quick to hand out powerful, dangerous medications just because someone said they were in pain. Pain has huge mental components, and it's still poorly understood. Even personally, I had knee tendinitis for years, before I lost weight and began strengthening the muscles around my knee. That pain always got worse when I was tired or frustrated, and it always improved when I was in a good state of mind. Now, I know chronic pain is far more complex than my case of tendinitis. I'm not trying to downplay people's chronic pain, but the principle holds true. It takes mental work to overcome pain, not just physical healing. Pain is inevitable in life. Sometimes we do need to know the cause in order to treat it, but not always. We don't need to have every answer before we begin the work of overcoming it, of building the mental strength to face hard things. The diagnosis isn't always critical to recovery. This applies well beyond medicine. In life, you don't need to know exactly what's wrong to move forward. You don't need every answer before starting a new endeavor. This paralysis by analysis mindset stops more people from taking action than actual problems ever do. Start, fail, start again. You'll learn far more through action than by reading or researching. This is especially true when starting a new career. You won't be an expert fresh out of school. Don't wait until you feel ready. Do it anyway. You don't have to identify exactly what your problem is, whether it's mental, emotional, or physical. The reality is we all have struggles that affect us negatively. What matters is what you do, what you choose to focus on, the problem or the solution. When you shift your attention towards solving the problem often shrinks. What you focus on becomes larger. Another personal story here. I had a compulsive hand washing habit from probably age 12 to my mid-20s. As a teen, I washed so often that my hands would dry out and crack. I'm not sure where the compulsion came from. I had an irrational fear of germs. When I became an EMT and later a paramedic, I washed my hands after every single call multiple times. Now, there's nothing wrong with hygiene, especially in the medical field, but I took it to the extreme. I could have spent time psychoanalyzing this compulsion, digging into where it came from, maybe even getting a formal diagnosis of OCD, but that probably wouldn't have helped me stop doing it. In fact, labeling the problem might have made it seem harder to overcome. Instead, I acknowledged the issue, excessive hand washing, and focused on changing that specific behavior. I didn't identify with the diagnosis, likely OCD. I focused on the solution. It wasn't easy. That irrational fear of germs took serious effort for me to overcome, but I did it without knowing all of the whys. Many people identify with their problems. They want a name for why they do what they do or why they don't do what they know they should do. This desire for a diagnosis can be helpful at times, but fixating on the diagnosis itself rarely solves anything. It's focusing on the wrong target. Labels like OCD, anxiety, depression, PTSD can be useful starting points. But for some people, the label becomes an identity. Their worldview becomes colored through that lens, and that lens can be deeply flawed. Someone with anxiety may see themselves as an anxious person, someone broken, someone who needs medication to function. They search for answers outside themselves instead of beginning the work within. To be clear, I know clinical anxiety is real. I know it can be debilitating, and I'm not dismissing anyone who needs medical treatment for it. But using that diagnosis as a crutch, a reason to avoid life's hard work, only deepens the suffering. I'm not saying people with real mental illness should just toughen up. I'm saying many of us have more strength than we give ourselves credit for. And then, of course, some people will get life-altering diagnoses. Cancer, multiple sclerosis, Alzheimer's. The truth is, none of us gets out of this life alive and healthy. Sooner or later, a diagnosis will be placed on all of us by medicine, society, and when that moment comes, we must decide, will this diagnosis define me or will I define myself? Don't let anyone, especially a doctor, define you with a label. Acknowledge reality, yes, but don't let it consume you. Don't let someone else's words become your identity. Even when a condition is irreversible, even when it's untreatable, you still get to decide what that means for your life. You define your story, not the diagnosis. This is easier said than done. It takes real work, but regardless of what you're facing, keep moving forward and bettering yourself before you have all the answers. If you're debating a career change, start taking steps today. Don't wait until you've researched every detail. If you're facing a scary medical diagnosis, take back control of your day in whatever way you can. If you're overwhelmed by a problem, quit analyzing it endlessly. Take action. Diagnoses are part of what I do every day, but the goal in life should not be to seek a diagnosis. Guys, I hope you found some value from kind of my introduction as well as the first emergency standard that I wanted to discuss. Give me your feedback, both good and bad. I'm curious what your thoughts are, and I'll see you next time.